Hello, my name is Risharine Archangson and I am from BISAMT 3B, and this is my quiz for our clinical chemistry, and this is my presentation. So first, I'm going to tackle about the exogenous pathway. So exogenous pathway is a dietary type of pathway in which it is a liver synthesizing lipoprotein. From our diet will give triglyceride and cholesterol, in which the triglyceride and the cholesterol is being absorbed in the intestine, specifically our small intestine. And then our triglyceride and cholesterol will become chylomicrons. Um, our triglyceride and cholesterol and also our chylomicrons are water insoluble. So our chylomicrons will enter our lymphs. So our lymph, it will drain into our thoracic duct. And then in the thoracic duct, it will go into our bloodstream. So we are here in our bloodstream. So in our bloodstream, we have what we call apolipoprotein, which is specifically our B48. So our B48 activates the LPL or our lipoprotein lipase. So our lipoprotein lipase is responsible for initiating esterification. So after esterification, the um, esterification, it will also for our fat metabolism. It also helps in that fat metabolism, especially in our muscle cells. There are two uh, there are two things that we can use, um, which makes our chylomicrons into fatty acids. Our fatty acids, we can use it in our muscle cells and also our adipose tissue. So in our adipose tissue, it is converted through into for future use for storage, and but usually most of it are goes to our muscle cells, and the excess fatty acids, since there are excess fatty acids, it will become our fatty acid remnants, and these remnants will proceed in our liver, and it will be through our bile. In our liver, it will emulsify there. So that's it in our exogenous pathway. The second part is our endogenous pathway. So our endogenous pathway is this. So first, let's define our density lipoproteins. VLDL is very low density lipoproteins. This is very bad, and IDL is our intermediate density lipoprotein. And then our LDL is our bad cholesterol, and our HDL is our good cholesterol. So first, our liver. So in our liver, it will use our fatty acids to convert our triglycerides and VLDL. So here we have our apolipoprotein E, apolipoprotein C, and apolipoprotein B 100. So in here, our these triglycerides and VLDL will go into our circulation. So in our circulation, we also have our LPL. So we have our lipoprotein lipase. So this converts our VLDL into IDL. So our IDL um, has a apolipoprotein E and B100 because our apolipoprotein C is removed when our LPL enzyme is being used to convert our VLDL into IDL. So our IDL will go into the liver. So it will go into the liver, and the liver has two ways. The total removal of our apolipoprotein E and the removal of apolipoprotein E through our bile. So in our bile, our IDL will bind in with the apolipoprotein E for our emulsification. So the other option is the total removal of, not total removal, just removal of apolipoprotein E, in which our IDL will be converted into LDL, and the only apolipoprotein left with the LDL is our B100, apolipoprotein B100. So in here, it can be used in 70% and 30%. So our 70%, most of it goes to the vial as well. But the 30% can be used in three ways. First is our cell membrane, which is what we know, our phospholipids, our glycolipids. And then the third is our steroidogenesis. So our steroidogenesis, it produces our steroid hormones, which are the aldosterone, cortisol, and DHEA. So these three are our steroid hormones, or what we call androgens. And then the third is it is being used, or LDL is being used for our atheroma. Atheroma, as we build up LDL, it is used there as oxidized LDL. So we will tackle it later in our atherosclerosis. So in our liver and intestine, it produces the nascent HDL. So our nascent HDL, or the newly born HDL, has apolipoprotein A, C, and phospholipids. So these HDL are the ones that is responsible in getting rid of our LDL. So normally, if there are many HDL, our LDL will be get rid easily. But if there is a low count or low amount of HDL, our LDL will be hard to get rid of. So the atheroma, it will undergo the HDL3 here in our atheroma. It will undergo esterification, and it has three apolipoproteins: apolipoprotein A1, apolipoprotein A2, and apolipoprotein C. And this HDL3 will be esterified, or will go through process of esterification by our enzyme lecithin cholesterol acyltransferase. It will convert the HDL3 into HDL2. So now it has two ways in which it can either go into the VLDL to the endogenous pathway again, or it will go to the lipid to become part of our bile and get thrown to the bladder for storage. So that is all in our endogenous pathway. So our third part or third topic of our video is our atherosclerosis. So our atherosclerosis is here. The 30% of our LDL can be in three ways. First is our cell membrane, second is our steroidogenesis, and our third is our atheroma. So we'll tackle our atheroma. So there is in our vascular endothelium there because of certain situation um, it has undergone into vascular injury. So because of that, it leads into our atherosclerotic lesions, in which is said to be the most um, common acquired abnormality of our blood vessels. So it is acquired, it's not hereditary. It means that because of our diet and lifestyle, reason why we have atherosclerotic lesions. So lesions in Tagalog is bukol. So diseases, we have 4 diseases stated here. First is our ischemic heart disease. When we say ischemia, it is the decrease of blood supply. So it is not hypoxia, because hypoxia is what we refer in our tissues. But here we refer it as ischemia in our blood vessels, specifically in our vascular endothelium, in our heart. So, nadadamage ang heart natin because of ischemia. And if matagal na yung hypoxia or yung ischemia sa part ng body na yan, it would lead to permanent damage or nagkakaroon ng permanent damage. And this is our ischemic heart disease. So next is our myocardial infarction. So our myocardial infarction is one of the fatal conditions that a person can have. So if someone is suspected with a myocardial infarction or AMI in our hospitals, acute myocardial infarction, we direct it from the ER to ICU immediately. So AMI is said to be it's said to have high mortality rate, and the usually clinical manifestation of this is myalgia or chest pain. So next is our stroke. Our stroke is this is our brain attack, diba? And our AMI is our heart attack. This is our brain attack. Stroke, because of the atherosclerotic lesions, it leads to stroke because of, for example, the targeted artery is located in our brain. So there would be a decrease of oxygen supply in that area of the brain, and the brain tissue will not receive enough oxygen to completely function well, and because of that, the viability of our brain will be compromised, and it will lead into what we know is stroke. So fourth is our gangrene of the limbs. So gangrene of the limbs, this is a condition in wherein the limbs or the tissues in our limbs, there is a pus formed there, and the tissues are dead or has undergone necrosis. So because of that, because of lacking of blood supply in that limb or area, is the reason why it became gangrene. For example, our left artery our left leg artery has clot or nagkaroon ng lesion doon sa ating vascular endothelium doon sa ating artery doon sa ating left leg. That resulted into gangrene of our left leg. So next is it treatable or reversible? What I would say is that it is manageable. So in our ischemic heart disease, we have oxygen treatment. We give oxygen to our patients. And then in our AMI, we observe them for 24 to 48 hours. And in our ICU. And in our stroke, we give them heparin because heparin is a natural anticoagulant of the body, and we shouldn't give other anticoagulants to our patients such as EDTA and other anticoagulants because it can be introduced as a foreign body, and the body would respond into hypersensitivity or immune response, and we shouldn't let that happen. So in stroke also, we also have to get rid of the clot, so some doctors suggest surgery. Here in our gangrene of the limbs, we have hyperbaric chamber treatment. So here in our hyperbaric chamber treatment, we put our patients into a chamber, and we give them, or we expose them into high concentrations and high levels of oxygen, and so hopefully we will give the patients the area of the infected area of the patients will regain its viability, and lessen the severity of the tissue death. So in our gangrene of the limbs, the gangrene, it is a environment in which it helps our bacteria to proliferate, dumami. So example of it are Streptococcus pyogenes and Staphylococcus aureus. So, and also other normal flora in our body. So this bacteria can cause opportunistic infection and would infect our patient, and would lead to more complications. Then we have our factors that affect predisposed to endothelium injury or formation of atherosclerotic lesions. So first, we have the LDL cholesterol hyperlipidemia. In this, our lipid concentrations is high. So our triglycerides, our cholesterol, our HDL or our good cholesterol, and our LDL or bad cholesterol. Specifically, our LDL or our bad cholesterol is high. So the LDL is also affected by the value of the triglyceride and our cholesterol. And next is our hyperglycemia. Our hyperglycemia is specifically our diabetic patients. Most of our fatty acids and triglycerides are formed from lipogenesis. So our lipogenesis, this happens when there is an excess glucose in the body. So next is our hypertension. In our hypertension, um, this this has usually a sign of high blood pressure. So the blood pressure or this is what specifically the pressure of the blood when it bounces off of the vascular endothelium. So pag pump ang blood, pag ma-pump ang heart rather, mag-rush ang dugo kung saan man papunta. This is the what we call positive pressure. So high blood pressure, of course, would result to vascular injury, and the vascular injury will make our atherosclerotic lesions and possibly cause diseases. So fourth is the increased toxins, bacterial infection, and viral infection. So in here, we have increased toxins because of cigarette smoking. So next is our bacterial infection, which is, for example, chlamydia pneumoniae, which targets our vascular endothelium. And next is our viral or virus, which is our CMV or cytomegalovirus, which also targets our vascular endothelium. And both of them can cause atherosclerotic lesions and lead to atherosclerosis. Next here, I will be discussing the procedure of our atherosclerosis, or how does it happen. So first, as we know, there is an increased level of LDL. So that would form into vascular injury because our LDL will go into our vascular injury, and it would oxidize there, and it would enter in our tunica intima, specifically in our tunica intima of our lining, or the lining of our vascular endothelium. And the atheroma in our blood vessel may cause myocardial infarction, and the decreased level of the good cholesterol, and the body would the decreased level of good cholesterol, the body would get rid of the LDL in the form of vascular endothelium, and the LDL will be eaten by our tunica intima. It will be eaten because since there is an increased permeability, there is also an increase of adherence. So our adhesins would adhere our WBC. So for example, our monocytes would enter our vascular endothelium, and this is because of our diapedesis. Our diapedesis is the rolling or the action of our WBCs when they are transporting from one place to another through rolling action. So our diapedesis of our WBCs, will adhere in our adhesins. So our adhesins in our vascular endothelium will eat our WBCs, and our WBCs, like our monocyte, will go into our vascular endothelium, making our macrophages. So our oxidized LDL will combine in our oxidized LDL will combine in our WBC and would form our foam cells. So our reactive oxygen species, we have 4, which are oxygen, hydrogen peroxide, OH negative, and O nitrite 00, and then negative. These reactive oxygen species are responsible for oxidizing LDL so that it would be eaten by our WBCs, or our macrophages in here, in our example. So when our foam cells accumulate, it would form our fatty streak. So our fatty streak, in here, when it would progress more, our tunica media will go into our tunica intima, and our tunica intima will produce our EMC, our ECM, our extracellular matrix. So our extracellular matrix because of our PDGF, our platelet derived growth factors, are the one that stimulates our smooth muscle from tunica media to tunica intima. And then our tunica intima, the process of PDGF is that the tunica intima of the smooth muscle cells will produce large amount of ECM. So our ECM is, as we know, there are 2 types of ECM, our proteoglycans and our collagen. And then the ECM components will also add to our foam cells, and the thickness of our ECM added by our foam cells will make will also make our it will also then our fibroblast no I'm sorry our ECM and foam cells will thicken in our lesion, and that would also make our fibroblast produce a fibroblastic capsule, and that fibroblastic capsule will protect our ECM plus foam cells, making our fibrofatty plaque. And when it is hard, or it also has a hardening ability, the ECM has a hardening ability. So when that is through, when that gets when the fibroblastic protective capsule will harden, it will make our fibrofatty plaque. So next is the fatty plaque will also be added with other things such as our WBC, our T cells, our cholesterol, the cholesterol in our urine, cholesterol crystals, or the plates staircase pattern. Those can also be present because it can be present because there is a increased presence of the oxidized LDL in the tunica intima and also other debris as well. So with the fibrofatty plaque, and in addition of other cells such as T cells, WBCs, and cholesterol and other debris, it will form a atheromatous plaque. Atheromatous plaque. So yes. So our atheromatous plaque, if further progression of this accumulation of lipid and loss of integrity of endothelium in our advanced lesions. So there is also a thickening of tunica media and calcification of accumulated external lipids, and there is also possibly necrosis within our lesions. And because of this accumulation of lipids and loss of integrity of endothelium, possibly would possibly make or would possibly lead to our most probably would lead to our blood stasis and clotting. When we say blood stasis, this is the decrease of blood flow or mismong complete blockage or pagsuslow down or no blood flow at all, and clotting because there is an aggregation of our cells and our platelets making or possibly clot in there, and because of our atheromatous plaque and clotting, it possible that magkaroon tayo ng occlusion or occlusion of the blood vessel. So occlusion means blockage of our blood vessels. So the blockage of our blood vessels can be in our AMI, in our heart attack, or in the stroke or in the brain, you know. And this the blockage of our blood vessels is our atherosclerosis. So our atherosclerosis can be in two ways, stroke and AMI. I forgot to put AMI here. Basta our atherosclerosis, our blockage can be in our AMI, specifically a blockage of blood vessel in our heart, blockage of blood vessel of large arteries in our heart or in our brain. That would be all, and